Okay, everybody, I think we'll get started. Welcome to October High Rounds. I guess it's oh gosh, is it the third one of the month? Probably. So we have one of my favorite professors, favorite doctors today, someone I've had the pleasure to work with for about 7 years. But I'm going to let him do his introduction because that's a lot easier for me these days. But David Moore, welcome.
Thank you.
Thanks for being here. Can you tell us a little bit about where you came from, how you got to UCSD?
Yeah, so I'm a UCSD lifer. So I came here for undergrad. I stayed for grad school. I did 1 year in Los Angeles and quickly ran back to San Diego. Did my postdoctoral fellowship here, and then have been on faculty since 2006. So my background is in clinical psychology. My training, at least initially, was in neuropsychology, but then I started to do a lot of what we call health psychology or behavioral medicine, which is some of the work that I'm going to talk about today. So interventions.
I guess you took away my next question. Well, actually, so what do you do your research in? Because there's actually a few different areas.
I do research in a lot of different areas. So what I'm going to talk about today is mostly medication adherence interventions using mobile technologies. So those have been both for people with HIV as well as HIV prevention studies for PrEP, which is where Jill and Sheldon, Eric, and I have worked together. So we've done work in both of those areas, but I also do work on HIV-associated neurocognitive disorders. I have a growing research portfolio on people who are aging with HIV. So.
Okay, and I asked David to think about a fun fact or just something he'd want to share with us about himself and his life.
So I know what Jill wants me to share as my fun fact, but so I'll give you two fun facts. Jill's fun fact for me is that I have identical twin daughters as well as a son who, when you have identical twin sisters, they get the limelight, who were on TV when they were babies. So they were on The Young and the Restless, and they were on House, and they were on a few TV shows. So that's the Jill fun fact that she thinks so. But my other fun fact is that when I was an undergraduate, I was pursuing really dual research careers in two very different areas. One was psychology, and the other was in tropical biology. So I spent about 6 months in Costa Rica studying forest fragmentation in butterflies, believe it or not. So, and I was trying to decide which path to take. And when I was spending a ton of time in the middle of this beautiful jungle alone counting butterflies, I realized that it was an amazing place to be, but that I wanted to be a psychologist. So that was actually the opening line of my personal statement for graduate school, was that in the middle of the Costa Rican rainforest, I decided I wanted to be a psychologist. So that's my other fun fact.
That is indeed a good fun fact. I still like the Young and the Restless story. Okay, we will let you take it away. Thanks, and have fun.
Thank you. So thanks for being here this morning, bright and early. I'm going to talk about a few different examples, but I really want to zoom in on one particular example of our mobile interventions for adherence. And then I'm going to go relatively quickly through the very first part, slow down a little bit, and then Emily Paolillo, who is a doctoral student working with me, is going to talk about one of her studies that is using mobile interventions or mobile assessment as well in people with HIV and alcohol use difficulties. So it'll be a dual performance. I have the special guest appearance by Emily. And I said to Marvin earlier that maybe this is one where the headliner isn't as good as the understudy. So here we go. So this is just a quick background. I try not to give too many slides that just have words on them, but basically to say that text messaging interventions for ART adherence have been shown to be pretty effective in improving adherence. So, and they've done a meta-analysis on this, and they've looked at various things. What are the components of the text messaging interventions that work? And they were basically 4 different things. So one was they sent less than daily messages. We actually don't do that. We send daily messages. they're bi-directional messages. So I send a message out to you, you send a message back to me. So that's really important that it's not just one-way communication, that it has personalized content. So it's not just the same thing over and over and over again. So that it's personalized and that they're matched to the dosing schedule of the participant. So if you had those 4 components, those seem to be the best intervention. And so we started doing some of this work, I guess it's almost 10 years ago now. And initially I was looking at people with HIV who had cognitive impairments, which was affecting their ability to take their medications. So instead of trying to improve their cognitive impairments, we just kind of skipped that step and tried to improve their medication adherence. So that's kind of the etiology here. So I'm going to talk about, in this case, 3 different instances of what we call ITAB. Individualized texting for adherence building was the name we came up with, and it's stuck. And we have kind of iterated this intervention each time that we implement it. So, and there's quite a few steps that we go through, and I'm just going to tell you what the intervention kind of turns out to be. So we do this at people's preferred dosing time. So people identify when they want to take their ART or their PrEP in some instances. We give them a choice of personalized reminders. Originally, we just had a small pool, about 40 to 60 messages that were really focused on health promotion. Like, you can do this, you can be healthy, those types of messaging. At one point, especially when we shifted to PrEP, our focus groups told us, we want to be entertained more. We don't want to be told that we want to, that we need to care about our health. We want to entertain us, tell us some fun things. So we added a really large pool of factoids. So these are just simple little things that are kind of like Snapple facts that go into the messages just to get people to read them. And we put a large pool of messages together, 400 or so. And then we have variability in the messages. So basically, it's just a random generator. It's automated. It goes in, it picks out a random message and sends it to them. We let people screen their factoids. So if they say, I don't want to know anything about science, or I don't want to know anything about music, don't send me messages about that. We get rid of those messages for them. So they can kind of have choice in there. Originally, we had people describe their pill so they wouldn't actually say what it was. Give people a choice of response options, like in our most recent iteration, instead of yes, no, and later, we had yeah, nah, and Z, which is like snooze. So these were things that participants wanted. And it's important to say that it's not wholly automated. So that it is automated, it goes out to people. But if they miss 3 messages, they get kind of, we haven't heard from you in 3 days. Follow up with us. And then if we don't hear for a consecutive period, we try and call them to see if everything's going out. So it's kind of a augmented support message system. So it's not wholly just automated. You could leave it at that point, but usually we do try and follow up. And each of the iterations is slightly different. So I'm talking in general about these interventions. So we use this kind of patient-centered approach in terms of developing content here. So we always do focus groups. Sometimes we do individual interviews as well. Really ask people, what are the barriers? What are the supports that help with their medication taking? We get feedback on the message content itself, the frequency of when to deliver these. We develop the intervention as well as a large pool of messages that go out. Those vary depending on the population. We do pilot testing, refine the intervention, do the study, share back with the community. It's a little bit of what we're doing right now, and then seek opportunities for implementing this on a ongoing scale. So the last step has been difficult, but I think we're getting close where we might be able to do this in certain settings. Okay. So here's some example. These are the 3 studies I'm going to talk about today. The first one, ITAB-M, was people with HIV who are current methamphetamine users. I've talked a little bit about this before. I'm going to go over this quickly. The TAPIR study was mostly MSM who are on PrEP, almost 400 people. We finished that study. And the study I'm really going to focus in on today is a collaboration through the CFAR Disparities Core with the Family Health Centers of San Diego. And we have some of the collaborators here today from Family Health Centers. And that's really focused on African Americans living with HIV who are at risk for non-adherence. So these are the various iterations of ITAB that we've done. This is actually not an exhaustive list, but it shows you that we've done this with hundreds of people now, probably approaching 1,000 people in different iterations of this. And again, this is the one that I'm going to focus in on the most. I'll tell you a little bit about this, which was only a 6-week study. This is with active methamphetamine users, and this was our first large-scale PrEP intervention. So this is the one, people with HIV who are active methamphetamine users. So they'd had to have some use within turned out to be the last 42 days. And this basically shows that we were able to get people to say that they took their medication, about 70% of the time. So that was quite good. And most of the time when you don't get a yes response, you just get no response at all. So what we found traditionally is people rarely say, no, I didn't take my medications. They'll either say yes or not respond. So what you think this means, whether you want to interpret that as they just didn't respond or it was actually a no, that's up for interpretation. The other part of this study was that we asked people about their meth use, which is here. We didn't say meth exactly. We used code words basically to say, we told people, we said, have you done anything today? And we were told them, this is about your meth use. So we didn't have to say meth in an open forum. And so what we found is about 20% of the time people would via text say, yes, they were using on that day. We also asked questions about mood, and people had varied responses. About half said they weren't depressed, and then we've got about 20% again that don't respond, and then varying levels of depressive symptoms self-reported via text. Okay. Quickly, some of the results from the study. Basically, as percent of days with reported meth use went up, adherence went down. And one graph that I don't have in the study, but probably the most interesting finding was that actually meth use over the study went down. So, the intervention, which was not focused at decreasing meth use, but focused on adherence behaviors, actually we saw a decrease in meth use. So, or at least self-reported meth use. And this is some work by Jessica Montoya, who's in the audience, one of my postdoctoral fellows, that basically shows that the more engaged you were with the system, the more likely you were to take your medication within a 2-hour window. And if you weren't very engaged with the system, meaning not responding very much, your adherence was pretty low. And then in the control group, it didn't matter as much, what your level of engagement was with the system for adherence within that window. So really engagement seems to be important. Yeah.
I was just curious with the decline in meth use. Did you have any hypotheses as to why that might have occurred?
So, it's probably, there are interventions which are just called self-monitoring interventions. The easiest one is if you get on the scale once a week, you're aware of your weight. People tend to, as a simple intervention, self-monitoring weight, people lose weight. So similarly here, if you're self-monitoring your meth use, in general, you might expect some decline in meth use. So, and Jessica is looking at, pursuing this as a further line of research, as well as maybe in another study that we're doing upcoming. So, yeah. So that may be one, it's just a hypothesis. So that was our meth study. Quickly going into a PrEP study. This was our MSM study. Sheldon's talked about this before. I've talked a little bit about this before. Almost 400 individuals, mostly MSM, who were randomized either to get ITAB as well as PrEP or just PrEP and standard of care. And the take-home message here was that it wasn't as great as we thought it might be, but that really in the ITAB group, this is at week 12 and week 48 for the ITAB group, and then week 12 for the standard of care and week 48 for the standard of care. And really where we saw the biggest differences in this group, that is what we call near perfect adherers. So you can see that in ITAB at week 12, you get about 50% who are near perfect adherers, and that's a durable finding. It lasts until week 48. In the standard of care, you get over around 45% of people at week 12 who are near perfect, and that drops to around 38% or so at week 48. So you get some improvement in near perfect adherence, and so you could say, well, you don't really need near perfect adherence, you just need this level in prep, but certainly I always say behaviors are done best when they're done daily, so that if you can maintain that, you have a better buffer against being at risk for HIV. And this is just showing that the proportion of positive ITAB responses, so saying, yes, I took my medication, correlated with the DBS level. So if you only said that you were taking it under 60% of time, well, your DBS levels were low. And then as your proportion of yes responses on this went up, so did your DBS level of PrEP. So that suggests that really our marker of self-reported adherence is consistent with a biologic variable of their drug level. Okay. So that's the studies I wanted to kind of blow through really quickly. These are data that I have not shown before and are part of our collaboration with family health centers. This is our IC, what we say our IC Change project. We had a long acronym to be able to say IC Change. But in general, this is African Americans with HIV that we're trying to improve ART adherence. So this is, our team has had some turnover, but there are some members of the team that I want to highlight. Rogelio Garcia is hiding out in the back there in the tie. Wave, Rogelio. Rogelio is the backbone of this study. He makes this study happen. He sees all the participants. He follows them. He follows up with the calls when people are having problems with their texting. He really makes this project tick. So, and that's Rogelio there. And then Elizabeth, who moved on, took a job. She was a postdoc working with me. She really was the person who helped coordinate and get this study started. And then Jessica, who's also in the room here, help take over just in terms of helping to manage the day-to-day of these studies. So I'm very appreciative that we have a great team. We have many other folks. Elena and Karen are both here as well from Family Health Centers, hiding out in the back. So it's really been a great collaborative relationship, and I appreciate it very much. So the basic premise was originally for this disparities grant, we were going to look at the Latinx community in terms of adherence to ART. But what we found was that at family health centers, their services for the Latinx community were excellent. And when we looked at the African American community, actually their adherence was the worst. So even though it's a much smaller community, we had the greatest problems with ART adherence in the African Americans at family health centers. So in San Diego, African Americans represent 5% of the county's population, but 13% of people with HIV. And we said, can we improve ART adherence using these ITAB? That was basically the premise. We're going to do this with 100 people. Originally, we were just going to have a 24-week study. Our program officer asked us to extend that out to 48 weeks. We actually gave people the option, and all but 3, Rogelio, chose the 48-week option, which was interesting. So to continue on. This just shows that, Family Health Centers is a great collaborative partner, super close by. And then this is kind of the premise in general. We have these focus groups, as well as we did individual interviews that helped inform our intervention. We had assessments. People got to choose what they wanted. They get their message one time a day. Then we get a calendar, which I'll show you, of their adherence, which we share back with them at their visits, and then hopefully improve adherence. One thing that I thought was really interesting to share is when we did these focus groups in the African American community, they were particularly sensitive about disclosure. So they really didn't want anything to say anything about HIV, and they didn't want anything to say anything about medications. So, we used to do messages in our high disclosure, which is really not very high disclosure. It's really kind of moderate to low disclosure. They wanted even lower disclosure. So we would have often these kind of, it's time to take your small blue pill or whatever. We'd have those types of things, or time to take your meds. They didn't want that information in text messages. So we went from this high disclosure again, which I should really rename it moderate to low disclosure, to super low disclosure. So things like, instead of time focused, it only takes a second to be adherent, basically just take a break from your day. And they know that they're in an adherence intervention. Or be covered, it's time to take your meds, take charge of your health. So these are super low disclosure messages. Yeah, Gabe.
Hey, David, did you have a hard time with the focus groups actually getting together all these African American participants living with HIV and to participate?
So we had 2 focus groups. We actually did not have much of a challenge getting them together. So they were relatively small. I don't remember exactly how many people. 6? 6 in each. So they weren't super large, but I found that the participants were very forthright. So this was a really common theme that came up across, was this whole idea of, don't say med, don't say anything about HIV. Just give me messages that are super low disclosure. So and that I'm thankful to the Family Health Centers team for helping to recruit those folks. So this was one thing. So basically, when people enroll, we show them the examples and we let them choose whether they want to be in the kind of moderate low disclosure or the super low disclosure, and people choose that. And we haven't looked to see how many have chosen which at this point, but we'll feedback on that. So this is the rundown of the study, baseline, and then every 12 weeks to 48 weeks. We have closed enrollment. Our target was 100. Recruitment, it is tough, but we found 90. And then we closed recruitment so we'd have time for the 48 weeks before the study ended. So we're close to enrollment. We saw our last baseline participant in July of this year. So these data are a subset of the baseline data. This is not any of the outcome data, but who did we find? Approaching 50, mostly male. Interesting, about 43% of them identify as heterosexual. 83% have disclosed their HIV status. And we have really low income, high unemployment rates. So we have 40% who are 60% unemployed, 40% employed. We have 60% less than $20,000 a year, and we've got 36% who are unstably housed. So, and then education levels, kind of a roughly equal breakdown. Some colleges the highest. And in terms of, we got 6% who are injection drug users, almost 35% who are meth users. Okay, so in terms of challenges for adherence, we've got a lot of them, right? So, and in terms of years of diagnosis, it's a relatively recently diagnosed group as compared to many of our other studies. 4 years, and we didn't make the requirement that they be detectable as an entry requirement. Basically, they're at risk given many of those other factors that we just listed there. And then we have rates of certain co-infections that we see there as well. And here you can see that our system is doing a lot of work, right? So we've sent out over 19,000 messages to these participants. We have about 80% responses of yes, okay? And like our other studies, most of the time when people don't respond yes, they're just not responding, okay? This is what we do at the visit. We have a calendar where we show them basically how many days they say yes, how many days they didn't. It's an opportunity for them to recognize, let's say there was a grouping of 4 red days or something together where they didn't take them or they didn't respond if they're, and people might give a rationale for that or think about what those barriers were. This is one thing that we want to be able to incorporate in actually on the dashboard to the patient that we're not able to do via text message, that if we move to a different platform, we may be able to let people see their own calendars in real time. Right now, it's something that's just done at the visits. Another kind of interesting finding that we've been seeing is this idea of self-efficacy for medication taking. And it's one of the questionnaires that we've given people, one of the things we evaluated. These are things like, I know when and how to take my medications. I can take my medications when there's a change in my usual day, okay? So there's a few questions, you get a total score. And what we found so far is actually that the people's self-efficacy for medication taking has improved over time. And the group changes mostly occur between baseline and week 12, okay? The within person changes are associated with increased self-reported adherence as well. So this may be, again, one of these side effects of the intervention where people's self-efficacy for taking their medication is actually improving over time. So before I close, I want to just say that we're really trying to live this model as much as possible, which is to get community input when we start the study, do the study, giving feedback to the community as we go along, evaluate our findings in relationship to the community needs. We've presented at the CAB, the Disparities CAB, and then feed those findings back into the community. So in terms of future directions, I think there's still a ton of work that we can do here. One is a question of platform, whether we continue in text messaging. I mostly maintained, maybe up until recently, that text messaging is better because it's really ubiquitous on everyone's phone. There are limitations of text messaging. It's an open platform. It's hard. You have to keep within character limits. You have to link people's responses to the ones that go out. So it's not perfect in that way. There may be ways to shift to app-based things that can look like text messaging. Question back here. And then we've been trying to give participants more, if we move to an app-based platform or a web-based platform, people would have more control over their messages, like they have vacations, those types of things. Trying to look at machine learning approaches to when people may or may not be adherent. There's some mixed data on intervening when people have missed doses. So there's a large text messaging study in Africa that basically said they used something called the WISE pill when people took the cap off. That in real time they were able to see that someone took the cap off. And what they did is when they're expecting someone to take the cap off and they didn't, then they pinged them. And that actually bombed because people felt like they were being too big brother, too monitored, didn't like it. And people just said, forget it. I'm not doing this. Not having someone watch over my shoulder when I don't take my meds. So it seems like a really good idea that you're trying to help someone. Oh, I noticed you didn't take your medication. There may be other ways to do that are less threatening or less big brother or less monitoring. But, so there's challenges there. It seems like it would be a good idea, but at least in Africa, it didn't go well. And then in our trans prep study that we're doing right now, we have combined phone motivational interviewing with our ITAB system to see if that can boost whatever effect we are finding. If you think back to that slide I showed about engagement, if you think about the lower left quadrant, those are people who are not engaged and they're not adherent. So those are probably the people who need something more. What that more is and how it works is still up for open dialogue. And then, really trying to take these things into the clinic and into the community. So, question.
Son, can you hear?
Yeah,
Yes. Were these people given phones or did they lose phones during the study?
good question. So the first was about phones and whether we give them phones. Second, about youth. So as it relates to phones, most people had phones. If they didn't have a phone, we gave them a phone with a plan. If they lost the phone we gave them, or it just magically disappeared, then we would basically firmly but gently tell them, we're giving you a second phone. We're not going to give you a third phone. So, and we would do that. And most people have phones, though. I would say the bigger challenge is, do people have stable plans? So, people have pay-as-you-go plans. They don't really want our phone. They want to keep using their phone, but then the stability of plans. So, and there are Obama phones and ways to support that. And so, there are some infrastructure thing, if you think from like a social work angle, that you could do to keep phones more regularly in service and optimal. As it relates to youth, we haven't really been focusing in on youth. There are a ton of text messaging intervention studies that focus exclusively on youth, and other social networking platforms to really as a way of intervening, working with that group that seem to have some promise. So I don't know if that totally answers your question, but yeah. Was there another question, Gabe? And then I want to make sure Emily has time.
Hey, David. So when I gave high rounds last month, I touched briefly on the fact that a lot of health researchers, the interventions that we're studying are not, are widely commercially available yet. So what do you, what specific steps do you envision for getting something like this actually widely commercially available? Something that could ultimately be downloadable.
Yep. So that's I think one of the big reasons why we're thinking about moving away from text messaging potentially in new iterations and moving to potentially an app-based setting, because I think that there is higher levels of scalability there. So right now, what people would have to do would have to kind of come to our group, and then we have to have some support for the for the servers, for people to monitor the systems when they don't crash. So there is some cost there. It's not totally free, right? So that hurts when you go to scalability, even if that cost is relatively minimal, like let's say $12,000 a year. If you go to UCSD and say, I'll give you this system for $12,000 a year, they say, no, thanks, right? So they have their own systems, they have their own things in place. So, so I think that it is a big challenge. And as a behavioral health researcher who's not an implementation scientist, I think that that's where the next step is, right? So we need more implementation scientists who are able to take things that worked and implement them. And there's a whole science behind that. It's not as easy or as straightforward as it seems like it would be. I know Jessica's interested in getting expertise in that, and other folks as well. But really, I think from a UCSD and a broad health intervention standpoint, we need more implementation scientists. And we need organizations to be open to the idea of opening their doors and saying, come on in, see how we're doing things, see where are efficacious treatments that might be able to help. And sure, we'd be open to implementing those. And that's hard. People have their existing systems, and that's a difficult thing to kind of open up your doors and say, come evaluate us, come see how we're doing, and then tell us the evidence-based interventions that might help improve us. So I think I think there's a lot of challenges there. So as far as our work, I think we are thinking of moving to more of an app-based thing now, because I think now apps have components that they didn't have before, like push notifications, things that really can put the messages in the forefront. You can see things like, a 1 on your app that you have a message to. So, and then it allows people to control their own settings in certain ways. So I think, and there's been a recent technologic improvement in that you can write code for both platforms, so you don't have to write the code once. So it used to be you had to write two separate sets of code for Android and iOS products. So so I think there's been some recent leaps that help make that feasible. So. Okay, last question, and then Emily's turn.
Very good update, David. Question though, you are self-selecting out people that are open for texting in your research. Are there populations where they have shown that texting will do nothing, that they're not going to be open to it?
I think those are the people who just don't end up in the studies. So, you know, I will say that, you know, there are a fair number of people who enroll in our studies who say, I'm not very good with text messaging. I'm not really that interested in this. I don't think it's going to work. It's not that everyone that we put on our studies is like, yes, give me this. So, and it requires some like give it a try type things. So it's not that every single person that comes in, and we have a lot of people who, and Rogelio can speak to this, who just have challenges operating a mobile phone, right? So whether that's because of problems with their substance use, cognition, or just lack of familiarity with technology. And we do assess those things, like how familiar are you with technology? How often do you use it? So we try and assess for those things as well. So we're gonna switch to Emily.
I just want to say,
and I'll take some questions at the very end too if we need to. So
working with David on our trans prep I am prepped study, people who are finishing the study at week 48 are asking if they can stay on, continue using iTab because they found it to be so useful. So it really seems to have some power, and I just want to praise David again for developing it.
Hey, I'm Emily Paolillo. I am a fifth-year doctoral student in clinical psychology, working with David Moore. He's my mentor and the chair. Oh, you have a acknowledgement. The chair to my dissertation project, which I'll be covering today. It's a study using mobile technologies to assess alcohol use and cognitive difficulties. That's self-reported, subjective cognitive difficulties among people living with HIV who are also drinking heavily. So we know that heavy alcohol use is a major risk factor for acquiring HIV and transmitting HIV, and heavy alcohol use is pretty common among persons with living with HIV. Estimated rates range pretty highly, but they're usually estimated to be about twice or more than that of the general population. We also know that heavy alcohol use and HIV infection are each associated with impairments in cognitive functioning and everyday functioning, and that comorbid heavy alcohol use and HIV puts people at much higher risk for neurocognitive and neurobehavioral impairments compared to either condition alone. So I won't go over this slide in too much detail, but it's really just to show, there are deficits in HIV and neurocognitive deficits in people who use alcohol heavily, and there are a lot of overlaps in these conditions as well. Neurocognitively, we see deficits in executive functioning, attention, processing speed, and really these have pretty high stakes associations with everyday functioning outcomes like independent activities of daily living declines, unemployment we see quite often, and as David was talking about, poor medication management, which then leads to greater HIV disease severity. So, one thing that's really needed in the field is a reliable and ecologically valid measure of neurocognitive and everyday functioning in this population. So at the HNRP here, we do research on neuropsychological functioning among this group. But in the real world, in the clinic, full neuropsychological batteries are pretty expensive and time consuming. And also, the data that we get from these full neuropsychological assessments don't always correlate very well with real world functioning. We get a sense of their cognitive abilities, but how does that actually translate into what they're doing in their everyday lives? So one method that we can use to better assess cognitive difficulties or these neurobehavioral impairments in everyday life is to use mobile technology. And mobile technology, can first help people identify individuals that are having these problems and then can help us follow them and monitor them between visits over time. So ecological momentary assessment is the term used for this real-time assessment using, sort of repeated measures throughout the day. And as I said, this can be delivered through mobile devices. Almost everyone has a phone. A lot of people have smartphones now in particular. And so this increases our ecological validity of these measures. We're asking people, how do you feel in this exact moment? They don't have to think about over the last 2 weeks, how many problems did you have? How did you feel? We're saying, how do you feel right now? Are you having problems right now? So that reduces these biases and recall errors too. And there are a lot of other benefits of repeated assessment. There are studies already showing that an aggregate mean of these repeated assessments is more accurate than a report at a single time point, thinking over the last 6 months, at your current visit, right? And then you can also examine variability within persons. So we know that, at a visit, somebody might say that they're very depressed, but that fluctuates over time. And what are the variables that can help us predict that fluctuation over time? So this repeated assessment can really help us evaluate that. There are a lot of studies that commonly use ecological momentary assessment to assess mood and substance use. There are a lot of good studies showing that this is really feasible and acceptable even in high-risk populations. And really great adherence for completing these surveys, 75 to 85%, and in similar samples. There are a lot of heavy substance using samples that people have conducted these ecological momentary assessment studies in. But so far, there aren't any studies using EMA to look at cognitive difficulties and this neurobehavioral functioning in everyday life. So our goal for the current study is to collect real-time, real-world data of self-reported cognitive difficulties via a smartphone-based ecological momentary assessment in order to, as I said, reduce response bias, maximize our ecological validity, and then also understand this within-person variability in cognitive difficulties. So our target for this study is 50 participants. We have started enrolling people. So far, recruitment is a little low, so we're going to be expanding that to the community. And we're only looking at HIV positive participants for this study, and they have to have reported high alcohol use in the last 30 days. We're using an NIAAA criteria for at-risk alcohol use, which is men, it's greater than 4 drinks per day or greater than 14 drinks per week. For women, it's greater than 3 drinks per day or greater than 7 drinks per week. So I'm sure you can imagine, I'm sure you see a lot of people that already meet this criteria. Anyone who's 18 plus, fluent in English. And then our only exclusion criteria here is a current substance dependence on any non-alcohol substance except marijuana within the last 12 months. And these are other criteria that are typically exclusionary for studies at the HNRP. A shameless plug here. I'm sure you do see people that meet some of this eligibility criteria. Please refer. This study is already funded. We're recruiting. I'm trying to finish my dissertation, and I'm really excited about the results. If you do have any patients, you can refer them to us. I'll have a slide at the end with our information. So the general study procedures here is that they come in for a baseline visit. It lasts about 1.5 hours, and they receive $30 for this first visit. They complete some baseline measures. We collect, baseline measures of mood, functioning. And then I train them on our EMA survey. So most of our participants so far have had their own smartphones, and they're allowed to use their own smartphones. But if anyone doesn't have a smartphone, we also provide that. And then they're assessed for the next 14 days by completing 4 surveys per day. The surveys last about 5 minutes, although the more they get used to the survey, people have said that they can complete it pretty fast by the end of it. So they receive up to 56 extra dollars, $1 for every survey they complete over that 14-day period. And then we bring them back after that for a follow-up. They complete some follow-up measures, participant satisfaction, and they receive $30 compensation for that second visit. I will say that some of our satisfaction data so far has showed people really actually have enjoyed the study. I think for, similar with a lot of David's studies, people kind of like that extra contact. They like being contacted and, it's showing that somebody is caring about them, asking them about how they're feeling. So far everyone has, circled the very high enjoyment on our feedback questionnaire. So our EMA survey is actually delivered through Qualtrics. They get a text message with a link to a survey 4 times per day, and the timing is set based on the participants' schedule. So we ask them when they typically wake up, typically go to sleep, and it's sort of randomized throughout the day based on their own schedule. And so all they do is, they click this link, it opens up the web browser automatically, and then we have items that assess cognitive difficulties. You'll see an example here. Since the last survey, have you experienced memory difficulties? And they can answer one of the following. We ask about alcohol use, how many drinks they've consumed since the last survey. We ask them how they're feeling currently. What are they doing right now? Who are you with right now? Do you feel any pain? How tired are you? And we ask them about other non-alcohol substances, of course, and about their antiretroviral medication adherence. And then, the final slide here, just to give you a sense of what we're really trying to do with the study. We want to evaluate the relationship between these EMA-reported cognitive difficulties and their objective neurocognitive performance. So, during the visits, we assess their neurocognitive functioning. And, the idea here is, can this real-time assessment of everyday functioning help us identify people with neurobehavioral impairments that are evident on our in-lab testing? And will this method yield more accurate identification than our typical standard in-lab or in-clinic self-report assessments? And then 2, of course, is we want to examine those within-person relationships between alcohol use, mood, even engagement in what we consider, cognitively demanding activities or activities that take a lot of mental effort, and their experience of cognitive difficulties. We know that there are lots of factors that can affect whether an individual reports cognitive difficulties. We see, in clinics and in labs, their report of cognitive difficulties don't really always associate well with how they're, functioning cognitively, and because those can be affected by mood and other things. So we're hoping that this research will really, elucidate some of these associations between people, and we can then target certain things during interventions later on. And exactly this, we can look at factors that affect changes in everyday functioning. So again, some of the relevance here is that neurocognitive and everyday functioning impairments among people with HIV who drink heavily lead to both individual and public health concerns. So remotely monitoring these cognitive symptoms might be one highly feasible way to identify individuals that need a full evaluation. We can also better understand the factors that influence cognitive difficulties. And also, cognitive difficulties are part of the criteria for evaluating everyday functioning impairment in the diagnosis of HAND, of HIV-associated neurocognitive disorder. So this might be one way to more accurately do that. And of course, mobile health is very popular now. People are wearing Fitbits and doing all sorts of stuff on their smartphones. Why not incorporate tracking cognitive health? So again, thank you for your attention, and please refer anyone you know who might be eligible.
Thanks, Emily. So the 4 times per day seems frequent. Did you have any formative feedback or formative, I guess, data informing that level of frequency, or have you had any feedback as far as, well, that's too much?
Yeah, that's a good question, actually. And 4 times a day does seem like quite a lot. So I modeled the 4 times a day off of other studies that we have going on at the HNRP. Another one of my mentors, ran a study assessing everyday functioning in older adults, and she does a 4 times per day. Have had a couple participants say, that was a lot of work. It was hard for me to, know exactly when the message was coming, and I felt a little anxious about, answering it on time. But most people, as I said in the feedback questionnaires, have circled that they really enjoy the experience. And I think a lot of the people who are not doing very much with their day actually liked that extra contact. But that is a really good thing to consider. And of course, we always emphasize there's no consequence to not completing a survey. Answer as many as you can. And so far, we've had about 80 to 85% adherence to all of these surveys.
I also want to say that, so Emily's like on participant 21. and she's an awesome grad student. So, but she wants to graduate and go on, and please do help her as much as possible. If you have any patients you think might be eligible, refer them, and we'll screen them and try and find out whether they're eligible or not. It's a really nice study, and again, I think we have social isolation in some of our patients and participants, and that while it may seem burdensome for some of us, for these people it's someone reaching out really and asking about them. So the last 1 minute, Crosby is going to tell us just about general studies that are going on at the HNRP that you can refer for, that most of which have a mobile component. So Crosby.
Yes, good morning. Hi. Good to see a lot of faces, familiar faces. I've been a recruiter next door at HNRC for 15 years. And if you would like to refer anyone for Emily's study, of course, here's the main number. I also brought my card if you want to call me directly, because that would just get my my office directly. And I would be happy to screen for this study. We don't have a flyer directly related to this study, so that's why I brought my card. But I do have flyers for other studies that have to do with text messaging for HIV positive folks who want to improve diet and exercise, HIV positive folks who are looking to reduce belly fat. So I brought a variety of those flyers. We also have one that has to do with neuropathic pain and cannabis use. And it also has a texting component. So if you're interested, there are flyers on the table as you exit, but I brought some as well, and feel free to take one of my cards. Besides that, thank you, David, for the wonderful presentation and the wonderful work you do. Thank you, Emily, for all your hard work. And here are some flyers that you can pass around. Thank you so much.
Great, thanks everybody.